Hey, good evening, everyone. My name is Netta Dismalchi, and I am co-moderating tonight's session with Dr. Ortiz, titled Erectile Dysfunction and Cardiovascular Disease, hosted by the Sexual Medicine Society of North America, as well as the American Society for Preventive Cardiology.
Hi, my name is Nick Ortiz, and I'm a reconstructive and men's health urologist at the University of Virginia. And today it's my pleasure to introduce Dr. Tobias Kohler, who's a professor of urology at the Mayo Clinic in Rochester, Minnesota. He specializes in erectile and sexual dysfunction and enlarged prostate. He is also the head of Mayo Men's Health and the Andrology Fellowship at the Mayo Clinic. Dr. Kohler is an active member of multiple societies, including the AUA, the North Central Section, and he is the president-elect of the SMSNA. Welcome, Dr. Kohler.
Thank you very much, Dr. Ortiz. Thank you for that kind introduction. So happy to have a robust audience here. Did you have something you were going to say?
Oh, no, I was just going to introduce Dr. Blaha, but if you want to go ahead and start with your session.
No, let's do the introductions first. That's a good plan.
Apologies. I have the honor of introducing Dr. Blaha. He is a professor of cardiology and epidemiology and is the director of the clinical research and director of cardiometabolic clinic for the Johns Hopkins Chickaroni Center for the Prevention of Cardiovascular Disease. He's a profound researcher with over 500 scientific articles with a focus on appropriate use of tests and new therapies in the preventive atherosclerotic cardiovascular disease. He's received multiple grant awards from the National Institutes of Health, FDA, American Heart Association, Amgen Foundation, Aetna Foundation, Bayer, and Novo Nordisk. He's a standing member of the Endocrinologic and Metabolic Drug Advisory Committee for the FDA. Not only does he do much research, but in 2018, he also received the Fred Breitka Award at Johns Hopkins for excellence in monitoring. He's mentored over 30 trainees, many of which have gone to hold prominent academic appointments. In 2021, Dr. Blaha was named to the Claviere Highly Cited Researcher list, representing the top 1% of world researchers. And in 2022, he received the Arthur S. Agatston Cardiovascular Disease Prevention Award, and it was the inaugural Dr. Bob Eckel Lecture at the University of Colorado. Clinically, he practices as a preventive cardiologist specializing in cardiometabolic diseases and the interpretation of cardiac CT.
Okay.
Thank you.
And I will go ahead and introduce Dr. Burnett as well. Dr. Burnett is the Patrick C. Walsh Distinguished Professor of Urology and Professor at the Oncology Center at the Johns Hopkins University School of Medicine. Dr. Burnett specializes in sexual medicine, major pelvic reconstruction, voiding dysfunction, prostate cancer, and lower urinary genitourinary tract malignancies. He's a world-renowned researcher in the science and medicine of male sexual dysfunction, including the science of penile erection, and was the lead urologic surgeon in the first ever penis and anterior pelvic transplant surgery. Welcome, Dr. Burnett.
Yes, thank you. Glad to be here.
Okay, I think we can go ahead and start with the presentations. What we will do is we will have all of our panelists do their presentations, and we will have a question and answer section at the end of the webinar.
All right, I think that means I'm up. I'm going to try to get my slides in presentation mode. There we go. All right. Well, again, thanks for that kind introduction, and very excited to talk about a really exciting topic. As a urologist, I love interacting with cardiologists because they're a lot smarter than I am. And of course, we all know that the heart is just its main purpose is to supply blood to the penis. All right. So by way of introduction, I have a few questions for the audience. What is the most common presenting sign of cardiovascular disease? And the answer is kind of a trick answer: heart attack. So often the first time we'll know that there's a problem, the guy's having chest pain in the ER, then am I. And what fraction of men who have a heart attack have normal lipids? Well, about half. So as a urologist, I'm like, man, we're really lousy at knowing if people are going to have heart attacks or not. So then the next question, spoiler alert here, what is the best independent risk marker of heart disease? Well, it's the penis in men. And then finally, how can we convince men that lifestyle change is important? And I think we need to leverage sexual function so they can start exercising and eat more fruits and vegetables, get a thinner waistline, etc. All right. So beyond that introduction, my task, it will be the following. I'm going to go a little bit over the Princeton panel, go over some penile physiology, some data, some psychogenic risk factor data, and then how to ask about problems with erections. So the Princeton panel started about 25 years ago after Viagra was introduced to the world, and all these men were going and asking for this medication. And we're like, hey, is this safe? What if these guys have a heart attack or heart disease? They can have a heart attack during sex. So the Princeton 1 panel basically established that really the risk of sex itself is not that great, increasing sudden cardiac death from like 1 per 100,000 person years, or increasing the risk of baseline MI per year from 1 to 1.01%. In general, normal sexual activity is 2 to 3 metabolic equivalents, equivalent to walking a flat mile in 20 minutes without any kind of problems, or climbing up a couple of flights of stairs in 10 seconds. Younger couples, sometimes they can expend a little bit more energy with intercourse, 5 to 6 minutes. And that's similar to 4 minutes on the standard Bruce protocol. Why does this matter? Well, the P1 through P3 forums basically set a way that we should ask men about ED and then risk stratify them based on their exercise tolerance. And we're going to let Dr. Blaha cover that in great detail. Finally, now we're fast forward to P4, the panel that I was lucky to be a part of, along with the other panelists today. And basically, we've pushed the envelope forward in terms of how we approach patients. And also, we're starting to incorporate coronary calcium scores and the role of PDE5 inhibitors and how really exciting stuff, how they may actually be protective for the heart as well. So as a urologist, I have to talk about the penis to a bit. In order to get a good erection, there are many things that are required. And on the picture, you see both a flaccid and erect penis. And you can see here that there's this layer of veins on the outside of the strength layer of the penis. And that's the venous system. And then inside are all this giant artery and these arterioles that have to fill. So when you talk about erections, you need to have active arterial inflow into the penis for it to work well. And that's what a lot of medications actually target to improve. Conversely, in order to keep erections, you need to compress the veins on the outside by getting a good erection. And when these veins don't compress well, that's something called venous leak. And that's a big cause of problems with erections as well. And that's sometimes men will wear a constriction band outside of the penis. And this is the type of ED that you need to fix typically with a penile implant surgery. In addition, you need to have an intact nervous system. You have to have nerves firing off from some kind of form of stimulation. And here's where adrenaline really matters. And if you have adrenaline, the nervous system enters the fight or flight response, and the penis does not play well when adrenaline is firing. If you're trying to run from a bear, it's not good to have blood in your penis. You want it in your legs and your brain so you can think to escape. And so that's why performance anxiety is a thing. As you're running from the bear, you want to not have good erections. That's so when guys are nervous during sex, it won't work. In addition, you need to have good testosterone levels. And recently there was the paper from the Traverse trial saying that testosterone supplementation does not increase the risk of heart attacks. And so this has to be normal for stuff to work well. And indeed, the penis is a use it or lose it organ, and you can lose length if it's not used for a while. So vascular versus non-vascular ED. So historically, Masters and Johnson said that 90% of problems with erections were in the guy's head or supratentorial. We know this to be exactly opposite of the truth, and 90% of the time there's an organic component. But the reality is that most of the time they coexist, both organic and psychogenic components. As this performance anxiety, we just talked about adrenaline, kicks in, you start to lose erections because of the adrenaline you're releasing, because of the doubt and the fear that you have from not being able to perform. Now, as we first discovered the link between erections and the heart or heart attacks, we kind of oversimplified things by saying, well, listen, the coronary arteries are 3 to 4 millimeters, penile blood vessels are 1 to 2 millimeters, and we know that as we get systemic progressive luminal obstruction of greater than 50%, we start to see symptoms. So thus, if a patient reads the textbook He'll get ED first, then he'll get his MI, then he'll have a stroke, and then he'll get claudication based on the vessel size. But that's probably oversimplistic and doesn't explain the whole story. Indeed, when we look at young men who have MIs, half to 2/3 of them don't have ED at all, right? And then there's also men with severe ED, which will never have an MI. So clearly, there's more to the connection than just this vascular connection. And what are some of the other potential mechanisms? Well, we may get into it in Dr. Burnett's talk, but endothelial dysfunction, these kind of things. However, we do know that ED severity, that is severe problems with erections, does tend to predict worse problems with heart disease and more coronary occlusion. The other interesting thing with ED is that it leads to depression and vice versa. And if you fix ED, that depression gets better, whether it's with pills or penile implant. There's awesome data showing you can fix this problem. So maybe that's part of it, is that we're fixing the mental aspect, the health and wellness of men, and that's leading them maybe to have more incentive to exercise or eat better because now they have confidence again. Who knows? I'd like to go over a little bit of the data, and Dr. Blaha is going to go over some of the meta-analyses, but basically this Inman study from the Mayo Clinic in 2009 showed us that they basically followed 1,500 men through time, and of those men, half of them developed like incident ED and the other half did not. When you look at this table here, you see the relative risk of having a cardiac event was just absurdly elevated, 50-fold higher here, 5-fold higher here in these different age groups, if they had incident ED compared to their age-matched peers that did not. And this is the first one of the big signals that we said, oh my gosh, this is a huge correlation. Similarly, there was a Western Australian study. They showed a similar 7-fold increase in young men with incident ED. But, when we talk about this 50-fold increase that Inman showed, that wasn't true heart disease. That was like cardiac events, like showing up in the ER, maybe having angina. It's not necessarily death or MI. And so, importantly, from these first two studies, we did learn that, and there's other data to corroborate this, primarily the PCPT trial from Ian Thompson's work, basically that if you have ED, you have a 5-year risk of an 11% chance of either dropping dead or having an MI, and a 4% risk of a 2-year incident ED to occur. So 1 in 25 guys that you just ignore that have ED or don't ask about will have an event. Similarly, if you have problems with masturbation, you also have bigger problems with cardiovascular disease. So now the best study to ever kind of link ED and cardiovascular disease later happened with Banks. And this is to the tune of 123,000 patients. And here we saw this kind of relative risk increasing of younger men fall away. So we're able to kind of account for other risk factors and effect modification of aging itself. And they found that all men, regardless of age, were at increased risk for MI and heart disease. And indeed, we saw that even severity of disease predicted things. This study, again, 115,000 patients, showed that heart failure increased, stroke increased, peripheral vascular disease, all-cause mortality increased to the tune of, I lost my slide there, trying to get this arrow. You can look here. Severe ED predicted all-cause mortality 2.3-fold higher than those that didn't get incident ED. So powerful stuff. Briefly, here is all the studies, if you want to look it up, and there'll be references, which I'll show briefly at the end, of all the data that's excellent at linking definitively ED as a harbinger for cardiovascular disease. It's just insurmountable at this point. But now hold on a minute. This is all vascular disease that we know to be true. There's also now studies showing that psychogenic ED predicts coronary artery disease. So 2 large meta-analyses in both 2017 and 2021 showed that guys with psychogenic ED, and after accounting for all these risk factors, had similar increased risk of heart attack and death as we had for the vasculogenic ED, which is crazy. And we're still not convinced. The P4 panel is like, okay, we should get more data. But this signal is very powerful, which basically means at the end of the day, regardless of what the ED is from, you should probably do a cardiovascular workup or at least think about it. So how do you ask about problems with sex? Very simply, you say, do you have any problems with sex? If you don't ask the patient first, they often will be too embarrassed to bring it up. And even if they don't want to talk about it the first time you bring it up, it typically normalizes it so that the next time, maybe they'll have the courage to bring it up themselves. You can use fancy questionnaires like the IEF-6 study or the SHIM score, but you don't really need to do that. Basically, you want to say, do you have problems with sex? You want to ask about, do you have problems getting erections, keeping erections, or both? And does this cause distress? If it causes distress, obviously there's going to be more of an impetus for treatment. But regardless, if they do have problems with erections, you're going to want to investigate potential cardiac problems. And just as a little bit more into the weeds, when guys say they have problems with erections, you want to ask, how? Is it obtaining, maintaining, or both? Is it partnered versus non-partnered? Because one tries to get more at psychogenic versus true vascular. And then also when. Often men will confuse ejaculation problems. If they have premature ejaculation, they'll lose their erection, then they'll call that ED. So sometimes you have to say, okay, when does the erection problem occur? Does it occur before or after ejaculation? And that's it. And if they answer positive to these, send them to a friendly neighborhood urologist for treatment, or go ahead and start PDE5 inhibitors. And again, Dr. Burnett's going to cover that. So what are the stakes, just in summary? Well, again, cardiovascular disease is the leading cause of death, in which half of all men who die suddenly never have CVD symptoms. The majority of men who have a heart attack have normal cholesterol, or maybe half, right? And remember that between 1/3 to half of all men less than age 45 and 90% of all men older than age 65 will have ED in combination after their heart attack, right? After they've survived it. And that's at least mild ED. And if it's moderate or severe ED, it's going to be worse. The ED often predates the first MI by about 2 to 5 years. We've got many studies showing that's the typical timing. And again, there are those incident rates that I talked about before. 1 out of 25 men will have an event within 2 years, and about 1 in 8 men will have an event within 5 years. The bottom here, you can see this graph of men just basically asking for treatment for erectile dysfunction and getting treatment. And we see here that the majority of men, the average age at which men ask is age 58. There's a ton of guys much younger in these other bars that have ED, and they've had these other, risk factors for heart disease. And so we got to ask men, regardless of age, do you have problems with sex or not? And if they do, launch the investigation further. So in conclusion, ED inquiry offers a unique opportunity to both diagnose and intervene for heart disease. I mean, it's one thing to tell a 65-year-old guy that they should start dieting and use weight loss and eat more fruits and vegetables, have a slimmer waistline. But if they do that at age 30, we can prevent the widowmaker, and they have a lot of opportunity to improve their lifestyle. There's definitive evidence linking these two conditions for sure. And it extends beyond vascular mechanisms, as we previously thought. Maybe it includes this depression link or other links, which we're yet to discover. Younger age gives us a better opportunity and indeed a better fulcrum for change. Because if I tell a young man, hey, if you lose weight, stop smoking, your penis is going to work well, that's a much stronger incentive than saying, you have an arbitrary risk of having high blood pressure or an MI 18 years later if you do such things. And then finally, again, regardless of age, we should ask. All right, that's all I have to say, and I'd love to turn it over to Dr. Blaha next. Thanks so much.
That was awesome. Some awesome points there about age. I think it was very important to talk about how earlier age of onset raises the risk more, and that leads right into the discussion of prevention, right? Because the idea of prevention is we want to detect risk factors earlier in life. So let me load up my slides here and go into full screen mode. And we're going to talk about erectile dysfunction, how it's a strong risk enhancer. I'll tell you what that word risk enhancer means and how we use it. That deserves further risk evaluation and counseling. So let me kick things off by going through a case. This is a case I actually presented at the Princeton panel too, that I think reflects all of our experience, whether you're from the urology side of things, the cardiology side, or maybe you're a primary care doctor. Just as we talked about, a younger man, 47-year-old man, presents to a urologist, a men's health specialist, complaining of erectile dysfunction. He doesn't have a primary care doctor and hasn't seen any clinician for the last 10 years because he's healthy. Why does he need to see the doctor? So when he is visiting the urologist to talk about his ED, it's noted that his BMI is elevated. He's in the class 1 obesity zone. He's also in the class 1 or stage 1, what we call it, hypertension zone, where his blood pressure is higher than we'd like it to be. A blood panel is ordered, and it's pretty clear that his C-reactive protein is elevated. That's a test for subclinical inflammation. His triglycerides are elevated. His non-HDL cholesterol is elevated. These are all reflecting, once again, metabolic dysfunction, insulin resistance, and the like, all part of what we call a metabolic syndrome. And then later in the conversation, it comes up that his father had a history of coronary disease at age 63. And, he wonders if he's at the same risk as his father. So hopefully this case sounds familiar, right? A man doesn't come to the primary care doctor to talk about his high blood pressure, didn't lead the conversation with his weight or his metabolic dysfunction, but wanted to talk about ED. And ED is going to be a portal into understanding the risk factors for this patient. So ED is a risk-enhancing factor. There's just no doubt about it, but it's not on the list of risk-enhancing factors currently from the American College of Cardiology and the American Heart Association, which is a bad thing, something that we think should be fixed, and hopefully something that we can all advocate for on this webinar. But this is the list of so-called risk-enhancing factors in our cardiology guidelines. These are things that if you detect them, raise someone's risk maybe more than you would have thought otherwise. For example, family history, of course. South Asian ancestry actually raises someone's risk more than you would have thought otherwise. An elevated lipoprotein A level. But they also have a specific list of conditions specific to women on these guidelines. And absolutely preeclampsia, gestational diabetes, or premature menopause raise your risk of cardiovascular disease too. But what about the men specific risk enhancing factors? Where is ED on this list? Unfortunately, it's not there, and hopefully we'll get it in the next guidelines. We talked about this difference between vasogenic and psychogenic ED. I'm certainly not the right person to talk about the details here. And certainly we just heard that even psychogenic ED can be associated with elevated risk. But I'm going to focus more on the vasculogenic ED, because that's where a lot of the data I'll be presenting comes from. So I wanted to talk about this study. This is a study that we did. This is done from the multi-ethnic study of atherosclerosis, and is one of the ones you saw on the tables in the last presentation too. I personally think this is one of the most rigorous epidemiologic studies. It comes from one of the well-known cohorts, the multi-ethnic study of atherosclerosis, follows patients over time with adjudicated outcomes. And we made a strong effort to adjust for things that have been criticized in the past that could have been confounders of the relationship between ED and cardiovascular disease. For example, some of the things that have been said in the past, well, ED is only associated with cardiovascular disease because of its association with depression. It's only associated with cardiovascular disease because patients go on medications that cause both ED and cardiovascular disease. Or it's the risk factors, even the metabolic risk factors that aren't well adjusted for. So we made a strong effort to adjust for all those things, make sure patients were absolutely free of cardiovascular disease at baseline, follow them up for adjudicated events, adjust for all the things I just mentioned and more, and looked for incident coronary disease events or CVD events, which includes stroke as well. And this is 5-year follow-up after a simple one-question query about erectile dysfunction. And if a male patient had declared themselves having significant erectile dysfunction at baseline, after full adjustment, there's something like a 1.8 to 2-fold increased risk of coronary disease or coronary disease of stroke or cardiovascular death in the multi-ethnic study of atherosclerosis. So I became very convinced of this signal after doing this study and, of course, examining the other data. We have lots of it, as you just heard. And this one adjusts for many of the things that have been considered criticisms in the past of this relationship. Okay, so let's look at the meta-analysis. Let's look at meta-analytic data of the association of erectile dysfunction and cardiovascular events. This is a meta-analysis, as you can see here. And you can see the summary effect measure is something like, in this one case, 40 to 50% increased risk of cardiovascular disease, independent of other risk factors. A couple studies didn't show an association. Most did, very consistent. Something like a 50% risk in this meta-analysis. But importantly, it's higher when you look at the intermediate risk patients. Why are the intermediate risk patients important? Those are the patients in clinical practice we commonly don't know how to treat. They're not clearly low-risk patients, and they're not clearly high-risk patients. They're the classic middle-aged man who might have emerging risk factors, but nothing major. And we know that a vast majority of eventual heart attacks come from the so-called intermediate risk group. So that's very important data. Also, as you heard, the degree of erectile dysfunction in terms of its severity also predicts cardiovascular disease. The more severe the ED, the higher the relative risk of cardiovascular disease. Now, it's absolutely important that patients have higher heart attack risk and stroke risk, of course. But really, we're talking hopefully about earlier in the disease process. We're hopefully identifying patients at the subclinical stage. So this is an important study that looked at erectile dysfunction and its association with subclinical CVD, which we know that precedes events. This is looking at brachial flow-mediated dilation on the left. That's a test of endothelial function. A lower or negative number there means less function, less endothelial function. In this case, we're looking at carotid intima media thickness, a measure of the thickness of the inner layers of the carotid artery, which is highly indicative of risk, particularly at young ages. And you can see here, once again, consistent associations between ED and less favorable endothelial function, probably part of the mechanism, and a strong association with more disease in the carotid arteries. So this is really the model that's emerging, as you heard. There's lots of risk factors that probably are smoldering in patients long before we detect them. Many of those are tightly linked to dysfunction of the endothelium, dysfunction of the inner linings of blood vessels that lead to vascular dysfunction, which of course can manifest as chest pain, can manifest as erectile dysfunction, eventual heart failure, and the like. So probably a variety of risk factors, including inflammation, impact endothelial function, can manifest as measurable subclinical CVD and erectile dysfunction before the onset of clinical CVD. So this is important, and this is why we think subclinical disease is very tightly linked with ED and can be leveraged to determine which patients with ED are at the highest risk. This was a study done in clinical cardiology, once again from the multi-ethnic study of atherosclerosis. And this study looked at several domains, so to speak, of vascular function. Atherosclerosis, vascular stiffening, which you see the blood vessels with age and risk factors, and vascular dysfunction, which means actual poor performance of the endothelium in response to a stressor, for example, like a flow-mediated dilation. So these three domains were looked at, and not surprisingly, men with ED in the lighter blue here, and men without ED in the darker blue, when looked at in terms of number of vascular abnormalities on these tests, the more vascular abnormalities, the more likely someone had ED. That makes sense. That's reflected here again on the right. 1, 2, or 3 vascular abnormalities on a variety of tests that can be done in a research setting, the odds ratio for having ED goes up 5 to 6-fold. And at the top, we also asked the question, well, adjusted for the others, which one of these markers is the most tightly linked with ED? Partly perhaps because of the nature of these tests and what's really available, but the test that really became out as the most closely associated with ED is subclinical atherosclerosis, test for subclinical atherosclerosis, particularly in this case, CT scans of the heart that reveal early plaque. Okay, so let's go back to our case. Remind you, it's the middle-aged man, came in complaining of ED, but clearly had, I think we'd all recognize having metabolic risk factors. Nothing crazy, you don't need to admit this patient to the hospital. But there's multiple things brewing here that when you let that patient go without talking about the risk factors, you feel like you're not doing what you can do. So what might happen to this patient? Well, it could be given Viagra and told to come back in a few months. Probably suboptimal, at least from a cardiovascular point of view. You could get testosterone testing, Viagra, as well as advice to go see a PCP and talk about those risk factors that he has. That's a start. But I think even better where we're headed is this patient should get a full ED workup, of course, and he should get integrated into a comprehensive men's health clinic, which can be run by urology, cardiology, or ideally both, and get a full comprehensive cardiovascular risk assessment at the time. And one of the reasons I became interested in this area is when Dr. Kevin Billups was with us at Johns Hopkins, we had a great relationship where he would see patients with erectile dysfunction and send them to me for cardiovascular risk evaluation. And I tell you, I found more subclinical disease in that population than my referrals for people with, say, family history or cholesterol disorders. Not surprisingly. In several patients I still follow to this day, many of which have had multiple events in the meantime or had revascularization. Okay, so what about the weaknesses of risk evaluation? So the only risk score that includes erectile dysfunction in the calculation of risk is called the Q-risk calculator. It's in the UK, and I'm sure that none of you use it here in the United States. But here you can see that, for example, this particular 55-year-old man has a risk of 9% in this calculation if he didn't have ED, and 11% if he did have ED. And this calculator raises risk about 25 to 30%. Somewhere in the 25 to 100% increased risk ranges, depending on what you adjust for, is what you see with ED. But this is an example of how ED can modulate risk. But if you look at the ACC-AHA risk calculator, erectile dysfunction is not in there, right? You plug in your patient's age and race and cholesterol and so forth, and you calculate a risk, which you see in the top. And here's the algorithm. It's complicated, so I won't go through it in detail, but basically it says if your patient's sort of in the middle zone, in the borderline to intermediate risk zone, like many middle-aged men are, you're supposed to consider the so-called ASCVD risk-enhancing factors, which I introduced at the beginning. So that patient had, high Lp(a), or was a woman who had a history of preeclampsia, you're going to raise the risk of that patient, perhaps be more aggressive with their treatment. But ED is not found on this list, unfortunately. So we need to do more to risk identify these patients. And it does say if your patient's in the middle, in the borderline to intermediate risk zone, particularly if they have risk-enhancing factors, you consider a coronary artery calcium score, which is now the preferred test to test for subclinical disease and increased cardiovascular risk. So what is the calcium score? Hopefully you've seen patients who've had them done, or maybe you've had one done yourself. Very accessible test, can be done on any modern multi-detector CT like you see here. The patient here is shown in a gown, but they could easily be in street clothes coming out of your clinic. They just need electrodes on their chest because it is gated to the cardiac cycle. Comes at about 1 millisievert of radiation. That's about like a bilateral mammogram. So some people refer to this as the mammogram of the heart. It has some appeal, thinking about it that way. Certainly, woman's is concerned about breast cancer, should be concerned about cardiovascular disease too, but a man certainly needs to be concerned about cardiovascular disease. And these are the images that you get. They're unenhanced images of the heart. So things that are bright are highly attenuating of X-rays. So as long as you don't circle the bone or potential calcification of the aorta, for example, the remaining what you see is typically coronary calcification. And with the software, you circle it and you get a coronary artery calcium score. And it's indicative of how much plaque you have in your arteries. And it's exquisitely tied to risk. This is well established in the cardiovascular guidelines. And I won't go through this in detail, but more and more guidelines are coming out like this. This is just a complicated cholesterol pathway, but suffice to say that you pick how aggressive to be with cholesterol lowering based on how high the calcium score is. So more and more guidelines are like this. Makes sense. The more plaque you have in your arteries, the more aggressive you're going to be. Here it says if you really high calcium score, you're going to be very, very aggressive with cholesterol control. So that brings us back to the Princeton 4. This is a figure you're likely to see in the proceedings of the Princeton 4. And this was our discussion about the cardiovascular workup of men with vasogenic ED. So let's start at the top here. Of course, you start out by asking for ED symptoms as part of really any assessment, or certainly the assessment of a patient coming in at risk. Of course, if they don't have ED, that's really not what we're talking about with this guideline. But if they do, you try to assess whether it's a suspected vasogenic mechanism. Maybe in the future, we're not going to really care as much whether it's vasogenic or not based on the data we just heard. But let's just say it is vasogenic. That's certainly going to raise your thoughts about cardiovascular disease in this patient. So it says you start by calculating a typical 10-year risk for the patient, and you consider their risk-enhancing factors and have a discussion with that patient, and you consider ED a risk-enhancing factor whereby you're going to be more aggressive with your workup. So it says that patient comes out as otherwise low risk. You're going to once again reevaluate the ED physiology. And if you think that person has vasogenic ED, you're going to bump them up and do a calcium score. Because that low-risk patient, we know a lot of low-risk men still go on to have heart attacks. You've now identified someone who's manifesting potential vascular abnormalities. Get a calcium score because that might drive your management to be more aggressive. If they're borderline to intermediate risk, many of your middle-aged men with ED are going to be here, do a calcium score. Now, typically, if they're high risk, we won't do a calcium score because we already know they're high risk, but most of your patients will be in this zone, at least in the younger ages, and you can see if the calcium score is elevated, we're going to be more aggressive amongst a variety of pathways. Lifestyle, statin therapy, LDL goals, and also things like blood pressure control or maybe an aspirin. Sort of outside of the scope of what we'll talk about today, but suffice to say, we're going to be more aggressive. And it says here, if the score is really elevated, and let's say you're a urologist, you're going to refer that patient to a preventive cardiologist, hopefully on your team. in a men's health clinic or at least at your institution for a full workup. So I think this is a pretty simple thing. It's actually simpler than what Princeton has presented in the past. You got a patient with ED, they're not high risk. You think it's vasculogenic, get a calcium score. If it's elevated, refer them to a cardiologist. I think that's what it boils down to. So the question comes up then, well, what about a patient with existing cardiovascular disease? So how do you manage ED in someone that you think has existing cardiovascular disease? They could have a very high calcium score. They could have had a prior heart attack or something like that. Of course, you should be asking all of our patients. This is more for the cardiologist, but the urologist too, about sexual function in patients with existing cardiovascular disease. Let's say you confirm ED. We talked about discussion of psychogenic and vasculogenic ED. And if you're concerned about that patient's safety for sex, for example, or for PDE5 inhibitors, you're going to ask them, of course, about their symptoms. Are they having chest pain? Are they having shortness of breath? But importantly, what's your exercise tolerance? What's your kind of, you do the historical stress test, right? Ask them questions about what happens when you walk the stairs, what happens when you do have sexual intercourse, what happens, et cetera. And particularly when there is symptoms or very poor exercise tolerance, of course, that patient may need to be evaluated by a cardiologist before we tell them, you're safe for sex, you should get, you should be evaluated before you get a PDE5 inhibitor. But most of the patients you're going to talk to are going to be non-high risk in terms of their exercise tolerance. They're going to say, no, I don't get that short of breath. I don't have active chest pain. I might have risk factors, but I'm not actively symptomatic. Most of these patients can then be reassured that they're safe for sex, and they could be safe for PDE5 inhibitors. If a patient has indeterminate symptoms, that's where a stress test comes in. Sometimes if you really can't take a clear history, it's not so clear what the patient's exercise tolerance is there, we can get a stress test and decide if they're unsafe or if they need to be further evaluated before you give them the green light. But most of the time, that's going to be negative, and you're going to most of the time be able to reassure I think it's a key message, most of the time be able to reassure a patient that they can be safe for sex and safe for PDE5 inhibitors. And we'll hear, I think, later that PDE5 inhibitors may be safer or even more beneficial than we thought on the cardiovascular angle. Okay, so let me conclude by saying to my cardiology colleagues that urologists may be seeing higher risk primary prevention patients than you are. And we might be missing those patients, and that vascular ED should be considered a risk-enhancing factor. And you can definitely save lives by conducting advanced risk assessment and focused prevention in men with ED. And I think that most patients with ED and elevated cardiovascular risk are still safe for sex and PDE5 inhibitors. I think we should provide mostly reassurance for patients who are actively symptomatic. If you manage the risk factors, we can increase their quality of life. And only those patients who have exercise intolerance or symptoms or require functional testing like stress testing. I don't think, like in the past, Princeton guidance might have recommended a routine stress test in such patients. I don't think we need that anymore. Most of the time, for patients asymptomatic, they don't need a stress test. They need a calcium score and preventive therapy, but not necessarily that pathway of stress test and cardiac catheterization and stents. We're past that now. And most patients with stable CAD nowadays who aren't actively symptomatic don't require frequent nitrates. And really, we don't need to be as worried about a PDE5 inhibitor being, let's say, contraindicated in some of the coronary disease out of the concern they might be taking or need nitrates, because most patients can be managed with medical therapy without nitrates and are safe for PDE5 inhibitors, in my opinion. So thank you very much. I'm going to pass it on, I think, to the next speaker, Dr. Burnett.
Terrific. Thank you for allowing me to present. And let me get to my screen. Sorry about the confusion here. Seeing my slides?
Yes.
Thank you. All right.
But I think you want to switch out a presenter for you into
let me see if I can switch it. How's that? Is that better?
There you go.
All right, good. All right, well, I have the task to follow with my wonderful colleagues, and I want to thank all of the viewers. I think this is a great program, and I'm delighted to be part of it. I'm going to speak to erectile dysfunction treatments and cardiovascular health, and hopefully complement what you have heard. By way of disclosures, a couple of entities, primarily with regard to research activity that I'm involved with, including clinical research. And so my objectives is to present the cardiovascular risk associations with ED, although this will be very brief because that's already been presented. Most of the talk will have to do with some of the clinical therapeutics with consideration of how cardiovascular disease may impact, and then the role of PDE5 inhibitors, both for ED management in the context of other therapies, but really a focus there, and as mentioned, a possible cardiovascular disease benefit. Now, as we already heard, there are some risk factors. I've listed these here, and I think we've already touched on these, so I won't dwell on it. But certainly we recognize a variety of factors. There have been various studies. I was able to engage in a study with our group here in the School of Public Health with the NHANES database, and we were able to look at risk factors. And I think we've heard all of this here, that ED is prevalent. It affects men of all ages, greater men of older age, and there are comorbidities that are largely associated, including cardiovascular risk factors. Now, managing ED and giving you a perspective from the sexual medicine urologist, we do recognize that this is a true entity, a true problem presented by the patient. And while we now have PDE5 inhibitors, which might suggest there should just be a simplified management for ED, rather we still think it is a structured process, and it incorporates clinical practice concepts to bring the best therapeutic outcomes. And there are a variety of concepts to be considered. We touched on some of these throughout the presentation already. Cardiac risk assessment that we just heard, a variety of approaches. Although the most recent erectile dysfunction guidelines, as shown here, is that we've accepted that there should be a shared decision-making framework, recognition of all of the different ED treatment options, an attempt to describe all of these in terms of their risk benefits, and then understand the patient and partner preferences to find the best outcomes that will allow for the patient to be successful. Treatment options for those in the group here that may be less familiar, as shown here, ranging from oral therapies to injections, vacuum pumps, urethral suppositories, and then surgically penile implants. Everything except for penile implants then are non-surgical. I do want to mention lifestyle conditions, and this was or modification, and this was part of the prior guidelines to acknowledge that men should be counseled to understand that dietary changes, exercise, discontinuing cigarette smoking, everything that Dr. Kohler had mentioned do fit within our guidelines and may have some potential benefit. As you can see, the recommendations are moderate with evidence that's grade C, while there have been studies looking at metabolic and cardiovascular conditions. These largely focus on general men's health, and we have inferred that there's some benefit with regard to erectile function. On this slide, I just wanted to just show the audience just really what we think are the efficacy rates overall. Again, the focus of the presentation today is PDE5 inhibitors with a range of efficacy rates for sexual intercourse. And the others do have some efficacy rates as well. Certainly the more invasive options really can produce the objective of penile rigidity. So let's talk about PDE5 inhibitors. They came on the scene in 1998. A few additional agents were then approved a few years thereafter. And the way they work, it relies on nerves and endothelium. Nitric oxide released from these cellular sources binds to the iron atom within the heme moiety of guanylate cyclase, activating this enzyme within the smooth muscle cell, let's say the corpus cavernosus smooth muscle cell, which then can convert GTP to cyclic GMP. Cyclic GMP leads a cascade of a mechanism through various protein kinases leading to tissue relaxation, and this is really fundamental for the blood engorgement for penile erection. The degradation or the hydrolysis of cyclic GMP involves type 5 phosphodiesterase, and a PDE5 inhibitor then blocks this enzymatic action, thereby promoting this action of cyclic GMP. So really this is the mechanism, and PDE5 inhibitors play a role. Now, what about success rates? I mentioned that the success rates for sexual intercourse can range up to 70%. Intercourse success rates may be somewhat lesser, and those who have diabetes or after prostate cancer treatments. And this is thought to be associated with cavernous nerve injury or lack of function, maybe with diabetes, mainly because of the nitric oxide release. But I think we can also consider that anything that has endothelial dysfunction also is associated with reduced NO release. That would be key to the mechanism of penile erection, to which PDE5 inhibitors promote the action. A word here about how we can consider strategies to optimize success. And all of this here is right from the slide: sexual stimulation, educating, re-educating patients, multiple attempts, dose titration, high-fat meals may result in delayed absorption. So really considering whether meal intake interferes with how the medication has its effect. Testosterone and lipid panels, optimizing the cardiovascular health, and treating comorbid conditions. So this is key here, in terms of discontinuing cigarette smoking, better diet, better exercise, getting the best vascular function that one may have to have the best effect from PDE5 inhibitors. And I just mentioned this here on this slide, that there are a host of other ways in which we may even combine PDE5 inhibitors for mental health counseling, all the way up to various sort of non-surgical but semi-intrusive treatment options. Now, this is a big portion of the talk here, and I'll just try to speak about this for the remainder of the talk. The interest here of PDE5 inhibitors is greater than that just for erectile dysfunction management. It's been used for lower urinary tract symptoms. There's interest in cardiovascular system, which I'll speak about in a moment, but even the neurologic system and oncology, there's some evidence that PDE5 inhibitors may have benefit. The interesting observation and hypothesis about whether PDE5 inhibitors may be cardioprotective perhaps cites the work of Rosano early on that looked at endothelial function and dysfunction with diabetes and had an early study that possibly showed benefit. And this is consistent with what's gone on in the literature with sexual medicine studies. Just for the audience, know that there are good scientists in sexual medicine have looked at whether there's factors of PDE5 inhibitors or other vasoactive drugs that may enhance the vascular endothelium and function within the penis. And this all then is consistent with how both the penis and the cardiovascular system really are linked and may be similar in terms of how they function. This nice study that I cite here went about looking at all of the possible mechanisms whereby PDE5 inhibition may be beneficial with regard to cardiovascular health. So really a more basic science kind of rigorous analysis. And I won't read through all of the different potential mechanisms, but these may include effects on blood pressure, improving cardiac contractility, platelet inhibition, and anti-inflammatory effects by all of these potential mechanisms in which there is some scientific support. Now, I'm going to tell you a little bit more about the hypothesis now of cardioprotection. There have been a few different studies, as cited here on this slide, that suggest that there potentially is cardiovascular benefit of PDE5 inhibitors. And then there was the notion here that we needed to move forward with a more rigorous evaluation to try and assess this. And accordingly, I want to cite the work of Bob Kloner, who had lent me some of these slides for his presentation, that I'll just go through the last few slides to try and stay timely here, in which the effect of PDE5 inhibitors were evaluated with regard to MACE, major adverse cardiovascular events, and mortality, looking at a large cohort of men using a retrospective nationwide insurance database. And what this involved was then 4 groups: commercially insured men with ED, but no MACE at enrollment, ED and no coronary artery disease, but cardiovascular risk factors, ED evaluated by level of PDE5 inhibitor exposure, and then ED and type 2 diabetes and coronary artery disease. So looking at these 2 specific disease subsets. And then this was a retrospective observational cohort study evaluating claims for PDE5 inhibitors, looking at the different PDE5 inhibitor drugs, evaluating for MACE with no evidence prior to study of at least 12 months, and then in follow-up. And the primary outcome was MACE, and the secondary was overall mortality with some rigorous statistical modeling. So the results here, nobody can read this side of the slide, so don't worry about it, but it just basically says this is a large study Exposed group was 23,000, unexposed 48,000 men, and then rigorously looked at. So each of the objectives, just to walk through that, the objective one was to look at commercially insured men with ED, okay, with no evidence of MACE in the 12 months before. And looking at this forest plot, the interesting finding is that for a variety of endpoints, overall MACE, myocardial infarction, coronary revascularization, stroke, heart failure, angina, cardiovascular-related death, and all-cause death, there seemed to be favorability in terms of reducing overall MACE and overall mortality. This is demonstrated nicely in this slide, looking at exposed and unexposed for adjusted survival curves, and by duration of effect up to 150 months, the survival probability seemed to be better for those who were exposed. Again, both for PD5 exposure, looking at overall MACE and PD5 exposure and overall mortality. Objective 2, men with ED and no coronary artery disease, but with cardiovascular risk factors. Again, for all of these endpoints on a forest plot, there seems to be improvement in overall MACE and overall mortality. Objective 3, by level of exposure, and I think this is the most powerful finding of this study, looking at to the best that they can subset these men by quartiles. The data for each of these endpoints seem to be beneficial, some a little bit more impactful than others, but overall 55% reduction in overall MACE, 49% reduction in rate of overall mortality. And this slide, I think, is nicely illustrative of this as well for a nice visual. If you look at the different quartiles from the lowest to the highest exposure, that the survival, the overall MACE and overall survival for mortality does seem to follow a dose response effect. So I think that was very interesting to see as well. Objective 4 was to look at the men with ED and different morbidities, type 2 diabetes. Again, forest plot endpoints all look like there's improvement there, again for MACE and mortality. And objective 4, coronary artery disease, similar findings. So very interesting study. The conclusions here suggested that for each of these subset of men, the objectives, that there was benefit. And of course, discussion points is that this is obviously a retrospective study. Although it does show some benefit, large study, there's suggestion here that doing a prospective study in the future may help us define this better, understanding that there may be limitations with retrospective studies in terms of any other confounders, knowing whether the men took the drugs and whether there may have been use of PD5 inhibitors that were outside of the insurance benefit. So I think this study nicely states that among men who took PD5 inhibitors, the rate of major adverse cardiovascular events declined by 13% overall. The decline was even higher for death from heart disease, 39%, unstable angina, 22%, heart failure, 17%, and even revascularization procedures at 15%. So I'm going to conclude by saying that ED and cardiovascular disease are intricately linked epidemiologically and scientifically. Both based on some of the data that I presented to you in terms of the science of PD5 inhibitor function and the science of erections as described by Dr. Kohler. The clinical therapeutics may be influenced by cardiovascular disease conditions, but they may also influence these conditions, and PD5 inhibitors may provide cardiovascular disease benefit. They may be potentially cardioprotective. So I will close there for the sake of being brief, and again, thank you to our moderators for the kind introduction, and I will, I guess, turn off my screen, right? Thank you.
All right. Thank you, Dr. Burnett and Dr. Cole and Dr. Blaha for this wonderful explanation and breakdown of ED and cardiovascular disease. We'll remind our audience that if anybody has any questions, to please place them in the question and answer section. We may have a few more minutes for any questions. I don't know if Dr. Asnaki has any questions that she'd like to ask at this time.
I'm glad to jump in, and I answered one already, and maybe I'll just rephrase that and say that out loud. So question was from Jared, a men's health urologist, and I made reference to advanced risk assessment, probably jargon that a cardiologist would use. But urology group says, well, we don't necessarily have the time or the capability to routinely evaluate lipids and so forth to calculate risk and go through these steps. I think that's nice when you can, but what do we do, I guess, to keep things simple? And one of the things I said in my responses, I think the idea with Princeton 4 is to keep things simple. Instead of naming a variety of tests that one could do, or a buffet of choices, I think the simple thing is if you can just do one thing, I would recommend a calcium score. If you said, you had a man that comes in and you don't know he doesn't know his lipids. Maybe you check his blood pressure, it is elevated, but you don't have that perspective on his lifetime risk. If you get a calcium score and just take the patients with high calcium scores and get them seen by a cardiologist, you'll find many of the events. About 75% of all events occur in patients who have a baseline substantially elevated calcium score. So even if we find just those patients and get them in to see a cardiologist, once again, probably 3/4 of the events will have been identified and perhaps treated. So that would be my simple recommendation. So hopefully everyone's got access to ordering a simple calcium score in their healthcare setting.
I have a question for you, actually, Dr. Blaha. In response to that, or to kind of piggyback off that question, would your approach be the same for a patient who was coming in with erectile dysfunction at the age of 25, 30 years old, similar to someone who's 65 years old, with maybe similar or no other cardiovascular risk factors?
So maybe let's have Dr. Kohler talk about just first. How would you approach this patient, a 25 or 30-year-old? I mean, presumably your questions would be a little different maybe than someone who's older. So maybe walk through that, then I can make a comment about the risk.
Yeah, the 25-year-olds is a common occurrence, and that often is psychogenic ED in that age population, produced by one bad night because maybe they drank a little too much, or maybe they used a substance they shouldn't have, and they lost confidence, or maybe they were with a new partner. Then it leads to this vicious cycle of performance anxiety. Remember that true ED that we're going to define as vascular in origin needs to have a greater than 3 months, and it's going to be both partnered and non-partnered, that kind of thing. Ultimately, these gentlemen end up getting a small dose of daily PDE5 inhibitors to gain their confidence back, and then you typically never see them again. However, if you give them a trial PDE5 inhibitors and they don't have success, then we would put them down the pathway of doing a penile Doppler to see if there is something going on. And there's good data linking, poor arterial inflow on the Doppler to whisk them off to the cardiologist or their primary care doctor for further cardiovascular assessment. That's rare, though, in a 25-year-old. But I'm always amazed, and you can tell me more than I know, Dr. Blaha. How often do you see these 35-year-olds getting MIs or getting stents? It's a lot more than we think, as far as I'm concerned.
So exactly, that's I think exactly the point. 25, I think, is certainly on the low end, and of course, it's more likely to be non-vasculogenic. I think really that's where we kind of recommend let's say a calcium score or a workup like that, and most of the time in vasculogenic. Now, of course, there's going to be sometimes not clear, but yeah, if you look at the data, about 1 in 10 men on unselected, 1 in 10 men already have evidence of plaque in their arteries by a calcium score at age 35. Now, that number is surely higher in the group of patients with ED, but already 1 in 10 of unselected patients off the street is going to be manifesting disease early, because this test picks up disease decades before, in theory, someone has an event. It can be decades. So I think usually about the age 35 is the earliest I'll screen a man with a CT scan with a risk enhancing factor. So that's probably when you start seeing, I'm guessing, more vasculogenic, causes of ED too. So I think that's that's about the tipping point for me, where I would, if I got a referral for a 25-year-old, I probably would not do much more except for check for lipids and things like that. But once we get into the 35, 40-year-olds, absolutely, the yield is going to be fairly substantial for looking for subclinical disease. Yeah,
and I'd venture to say that if I saw a 25-year-old, but his dad had MI at age 45, then I'd pull the trigger.
Right.
So I try to, as the urologist, try to ask about family history, because if they got ED plus a strong family history, I know they're in trouble.
That's right. And maybe they might have undiagnosed familial hypercholesterolemia, or one of these conditions that puts them at very high early risk. And we find them this way sometimes.
And the clinical history may be helpful too. If a young man says that he was functional and then suddenly an acute changes in erectile function, you have to presume there may be a psychogenic factor there. If he had been saying that pretty much all his adult life he's never very functional, and as you say, Dr. Kohler, that the family history could be a very powerful indicator too, and that may sway you a little bit more to look for this organic risk.
I've got a question for you guys. Can I ask a question? I don't think there's a lot of data out there, so maybe this is more personal experience, but it's a research interest of ours too. Of course, smoking is closely associated with ED. That's well known. But of course, a lot of young people nowadays aren't smoking; they're vaping, or they're using hookah or another tobacco product or heated tobacco. Do you guys have any experience or data to point to links between other tobacco usage patterns, like vaping, for example, in ED? And there's been some reports out there that haven't been pretty high quality, at least that I've seen. So I don't know what you guys see or what you guys think about that.
Well, again, the vaping generation tend to be very young still, and so time will tell. One thing that I can say for sure though is that priapism rates are up because of marijuana legalization. So that is a pro-priapistic entity. And so that definitely I've noted that people are partaking in that, and all of a sudden they're ending up in the ER with priapism. And of course, take a message for the cardiologists in the group. How do we treat priapisms? We inject adrenaline into the penis. Once again, reconfirming that adrenaline is the most powerful anti-erectile agent we have.
I think it's an intriguing question to ask, Michael, and I think as we heard, it's probably kind of phenomenon we're going to have to see here over time. I think we'll need to do some quality studies here, maybe. I don't know. These things are never easy to do, to quantitate this and understand this and remove confounding risk factors, but could be some interest because you start with vaping, then they move on to cigarette smoking.
That's true. Yeah, and
other habits, other substances, another bad habit. So that may be where the risk factor comes in.
Great. There is a question here on the Q&A box, and I think this is probably directed to our urologist. How do you assess a patient that claims that they do not have erections due to decreased desire, other than assessing for testosterone level? This may be a little outside the scope, but I don't know if you have any practical tips.
Yeah, I'll start, and maybe Dr. Kohler may have some additional thoughts. I think that again, as I mentioned in my talk, I think we want to be comprehensive. We don't want to minimize a presentation. We acknowledge the complaint. I think you do your vigorous and rigorous, that is, assessment, clinical history, and then the complete presentation history as well. And there may be a benefit to support that patient both on the side of their desire and try to distinguish what is the complaint. Is it, there is confusion sometimes in male sexual function as to what's really going on there. Is it sexual desire? Is it ejaculatory issues? Is it erectile dysfunction? And try to address that. So your specific question was, is it desire that's leading to ED, or is it just ED as a consequence of just having low desire? And if it's a primary issue, it may be testosterone, assessed for that, but there may be some other mental health factors, and that may actually need to be pursued.
I agree 100%. ED is like the perfect example of cognitive dissonance for desire. So if the penis doesn't work, you don't have desire to have sex. Nobody wants to play baseball if they know they're going to strike out, right? So, and then obviously we want to involve our mental health colleagues, our sexual therapists. There's different types of libido. There's lizard brain libido, where it's like, you turn your head at an attractive person that walks by. And then there's like relationship, I'm an established routine type of libido. And these are kind of independent entities. So it's a complex question, but at the end of the day, ask about antidepressants, take a good history, and then send them to a sexual therapist to get what is the underlying cause for low libido and treat the ED if they have it. Sometimes that fixes it.
Okay. I think we want to be mindful of everybody's time and maybe go ahead and close our session unless you guys have any final remarks. We thank you for for your excellent presentations today.
Thank you all so much. This was extremely interesting and definitely clinically changing for me. So thank you again for all being here tonight.
Thank you for having
Thank
us.
you. Thank you.
Take care, everybody.
With pleasure. With pleasure.
A lot of fun.
Have a good
Thanks,
evening.
team.
All right. Be well.